Hello and welcome to a special IGCS podcast. I'm Paul Cohen, a gynecological oncologist based in Perth, Australia, and the chair of the IGCS Education Committee. It's a great pleasure to welcome you all to this podcast. Today we're going to be discussing the United Kingdom National Lynch Syndrome Project, and in particular its e-learning modules which have been developed to support training and implementation of genetic testing for Lynch syndrome for all health professionals involved in gynecologic cancer care, including doctors, consultants, trainees, nurses, allied health professionals, and anybody looking after patients with gynecologic cancer. It's available at no cost on the NHS Hub e-Integrity online portal, and the link to the portal will be provided at the end of the podcast, so you'll be able to click onto that and register if you're interested to do the modules. I'd like to give a very warm welcome to our special guest today. First of all, Professor Ranjit Manchanda, who's Professor of Gynecological Oncology at the Wolfson Institute of Population Health at Queen Mary University of London, and a consultant gynecological oncologist at Barts Health NHS Trust and co-lead of Cancer Screening, Prevention and Epidemiology Unit. Ranjit's research is focused very much on targeted precision prevention, including population-based genetic testing, mainstreaming genetic testing and precision medicine approaches for cancer risk prediction. He's chair of the British Gynecologic Cancer Society 2025 annual scientific meeting, among many other hats. So welcome to you, Ranjit. I'd also like to welcome Hamda Mohamed and Rachel Perfect Lake, who are both clinical nurse specialists very much involved in the development of mainstreaming genetic testing for gynecologic cancer patients. And a very special welcome to Ruth Eilert, who is an endometrial cancer patient herself, and is very kindly going to share some of her own story and experience. So let's kick off. Ranjit, if I could start with you, just for some background, if you could explain briefly what Lynch syndrome is and why it's important that we test for it.
Thanks, Paul. Thank you very much for having us on the podcast and for the kind introduction. Lynch syndrome is an autosomal dominant condition where people can inherit faults in what we call mismatched repair genes, which predispose them to develop certain cancers. In particular, they're linked to endometrial and ovarian cancer, as well as colorectal cancer predominantly, although they could affect other cancers also, like renal tumors and hepatobiliary and brain tumors, etc. But these are the three main cancers to which they are linked. Testing for this is now advised and part of all our clinical guidelines. We know that approximately 3% of women with endometrial cancer will have Lynch syndrome, which has caused the endometrial cancer. Identifying those individuals allows us to give options of treatment, either for advanced or recurrent disease, in particular from the form of immunotherapy. So it helps that treatment. It's also got prognostic implications. And is used for classifying endometrial cancer these days from a molecular classification perspective. But importantly, it allows secondary cancer prevention in the individual, because the same individual would be at increased risk of bowel cancer. They could then access intensive screening for bowel cancer, as well as medical prevention, such as aspirin, which we know reduces the risk of bowel cancer in them. Additionally, it enables them share this information with their family members, and family members can then have gene testing. If they found to carry the familial pathogenic variant or mutation, then they can access primary prevention options or early diagnosis options, and that includes a range of options for screening prevention of whether we're talking about endometrial cancer or ovarian or bowel cancer. And we know that preventive hysterectomy, for example, in women once they've completed the family, usually after the age of 40 or so, prevents you from getting endometrial and ovarian cancer, and they would not have to go through the journey experience that their family member would.
And Ranjit, could I ask why do we just not take a family history from people? What are the limitations of just using family history, and how do we test for Lynch syndrome?
So testing for Lynch syndrome involves testing we start with the endometrial cancer tissue, and we look at the molecular profile of the tissue, and if it's deficient for any of the MMR genes like MLH1, MSH2, MSH6, and PMS2, then it may be suggestive of Lynch syndrome. Someone's got an MLH1 or an MLH1 plus PMS2 deficiency, then you need to rule out a false positive by MLH1 hypermethylation. And approximately about 10% of the tumors will fall in that category, who will then go on for next generation sequencing for one of these genes. Using family history-based criteria, particularly the Amsterdam-2 criteria, will miss 70% of people who actually have Lynch syndrome. So they're not effective at identifying individuals from an ascertainment perspective. And therefore, we shouldn't be using them. And that's why we use the molecular triage pathway now.
So just to clarify with you, the first test in the pathway is to test somebody's tumor after a hysterectomy.
Yes, and that can be often reflexly done. The pathologist would reflexly test the tumor, and when you get the pathology report, you would get the immunohistochemistry at the same time. They may also do other things like P53 and POLE, which is recommended for molecular classification these days. But from the Lynch syndrome perspective, it's the 4 MMR genes we're looking for.
Right. And also just to clarify with you, when you mention that's done reflexly, you're not talking to patients about that. That's the first step in the process, because that's not itself a genetic test. They're just testing for expression of the 4 proteins.
That's correct, Paul. And that is implemented in our center, and I suspect most centers in the UK, but also internationally today.
Yeah. So if that test suggests an abnormality, then you would talk to a patient.
Yes, then you would talk to the patient, and you would invite the patient in for discussing genetic testing. And that's correct, and that's what some of the teaching modules we developed lays out quite nicely.
Yeah. And in your center, that step or that counselling when patients are coming is done by nurse specialists.
Yes, predominantly nurse specialists, and we both are nurse specialists on the podcast. So I think they're both Rachel and Hamda. In fact, Rachel was instrumental helping set out the service. We also run a regular genomics Lynch MDT, where the pathologists, the nurses, the clinical team, and the lab team come together, look at results and triage and, deal with any problems or issues and make sure that the pathway works, both from the point of view of doing the testing, working through the process and the algorithm, but getting the test result back to the patient, enabling further secondary prevention that's instituted, such as like colorectal cancer screening and onward referral to genetics and cascade testing, etc., that is needed.
Thanks. So, Rachel, if I can ask you, tumors are tested and a proportion are flagged as potentially abnormal, and the patient may have Lynch syndrome. And then the patient is called. Who actually makes that call, and what? If you could tell us a little bit about the process, what happens when the patient comes to see you?
Yes, of course. So as part of my role, I developed a tracking system where for any patient that was diagnosed with endometrial cancer, we would record the IHC results for that patient. So we had a full oversight of which tests had been performed and could kind of easily highlight any patients that should be offered genetic testing. So once we had identified a patient, for example, who was deficient of MSH2 on IHC, at that point, I would either call or write to the patient, depending if I knew them in another setting, but usually write to the patient, just explaining that some additional testing could be offered based on the kind of routine tests that had been performed on the biopsy, and offering to book them in for an appointment to come in to have a discussion and to give them more information about what that testing would be.
And do most people go on and agree to have testing, or would somebody occasionally decline for a particular reason?
In my experience, we had a really, really high uptake of patients who did want to undergo kind of germline genetic testing to see if they carried Lynch syndrome gene. I don't have the exact figures in front of me, but I think it was in the region of kind of 90 to 95% of patients, after receiving information, made the decision with informed consent to have genetic testing. so kind of in our experience with that cohort of patients in London, there was a really high uptake in testing. Yes.
Thanks. And Hamda, if I could ask you just a little bit to sort of describe your own role, and also if you could talk a little bit about what you had to do in terms of training to be able to offer this counselling.
Yeah, so my background actually wasn't within genetics. So when I started this role at Queen Mary, I did undertake a lot of training to kind of equip me with the skills that I need to see patients and provide them with genetic testing. So I was able to complete the e-learning course myself when I was a new member of staff. I was able to shadow my fellow colleagues in clinic and see what they do and how they provide genetic testing to patients and what the processes are. I was also able to attend a course run by Guys in St. Thomas's, which is a genetics course for people who are not necessarily specialized within this specialty. And so I was able to learn quite a lot from that course also, and also learn from my colleagues who have a vast experience in providing genetic counselling within their practice.
Thanks. And so now you counsel patients by yourself.
Yes, I'm independent.
Results.
So I've been within my role for a year, and I think a year and a half now. So I'm fully independent and I'm able to counsel patients for genetic testing when they see us in clinic.
And coming back to the e-learning modules that you did, I wonder if you could just talk a little bit about those, how long they took, and the nerves that you put in from them.
Yeah, I don't think they take longer than a few days. I think it depends on how you learn. I am someone who likes to take a lot of notes, probably maybe too many notes. And so it took me maybe 2 to 3 days. It didn't take very long. Probably could have been quicker, but I just wanted to make sure I understood everything that I was being taught and understand comprehensively how I can, use this information and take it forward to my practice.
Thank you. And Ruth, if I could ask you from a patient's perspective, perhaps just to talk a little bit about your recollections of being called in and having this discussion, and what you remember about the genetic counselling, and then how you felt when you actually got the result back.
I was just asked if I'd like to take part in the genetic testing, being as they saying that I did have cancer, even though at the beginning when I had this hysterectomy, I didn't think it was going to be anything, so I was quite shocked that they said they found cancer. Because I felt fine. And then they asked if I'd like to take part in the genetic testing, which I said, yeah, as long as I didn't have to take tablets, because I don't like taking tablets. They said, no, it's just a blood test. And they would come back with the results. When I went to see the doctor, he just made me feel such at ease, and he explained everything that there was no reason there for me not to had the blood test. I had that done. I got the results back a few weeks later. I can't remember how long it took, but from what I can remember, I don't think that it showed up that I did have the syndrome, because I remember them saying to me when I had the blood test that if it come back, then I should have my 2 daughters tested. But I'm sure that they said I didn't have the syndrome, so everything was fine. And yeah, they just talked me all through everything, and yeah, it was fine. And obviously I was pleased that I didn't have it. I didn't want my girls to go through anything that I've gone through, but it's all been good.
Good to hear. Thanks very much for describing that. So Ranjit, if I could just come back to you to summarize, if this testing shows that a woman who's had an endometrial cancer does have Lynch syndrome because of a mutation or variant in one of the 4 mismatch repair genes, what does that mean for her? What does that mean for her family? What can she do about preventing other cancers?
For herself, it means she's at increased risk of bowel cancer, and therefore we would institute surveillance of colonoscopies maybe annually or once every 2 years, depending on what gene and what risk she had. And we would also advise aspirin. So our guideline currently is 150 milligrams per day, as per our British Society of gastroenterology guidelines. It's slightly higher if you have a higher BMI, pending, of course, the new CAP3 results, etc.
And that's because aspirin lowers the risk of developing bowel cancer.
Aspirin reduces the risk of bowel cancer. In Lynch in particular, there's randomized trial evidence to show that. It also lowers the risk of cancer overall, and it also lowers the risk of heart disease overall. So it's got other benefits. How it works, we still don't know, but it does work. So yes. So the other options, I guess, of importance are depending on the stage of the cancer, or if the person has recurrence, then it opens up treatment options in the form of immunotherapy. And of course, other family members on the same side who are blood vessels on the same side of the family can get tested, and we can identify people who are unaffected, and therefore get them specialist advice and options for screening and prevention. Also has implications for reproductive advice and for younger members of the family who may be planning a family, and things like pre-implantation gene tests, etc. come in. So yeah, and in our service, we have a specialist clinic, which is multidisciplinary, where we would invite people to come in, and once they get referred from their general practitioners or by genetics teams to us, we provide comprehensive advice on risk management and surveillance and prevention. And similar structures would exist in other parts of this country and in your center also, Paul, in other parts of the world. So they need a multidisciplinary management.
So this is really a very important opportunity, not just for the patient and potentially her treatment, either at the time or in future, but also for preventing cancer in her family.
Yeah. Yes, it's about saving lives and preventing cancer. Yeah, I think that's it.
And Ranjit, I wonder if I could ask you, and also perhaps Rachel, what led to the development of the national project and the motivation to put together these really excellent online learning modules?
We identified a big gap. There's a need, and the guidance came out, and there was a need to implement mainstreaming gene testing in endometrial cancer. But unlike ovarian cancer, which had been implemented earlier and is successful, we don't, mainstreaming in endometrial cancer has not been standardized and not been implemented. And therefore, to facilitate that change management, there was a clear unmet need to facilitate training in this area. And you don't need to be a genetics expert. You need to understand some of the basic principles and of the pathway and what we're doing, how to interpret results, etc. And so it's not difficult. It's not a difficult skill to pick up, but clearly we need colleagues to be trained. I think the mainstreaming gene testing at cancer diagnosis, I think, is going to come in for lots of solid tumors across multiple cancer types. Endometrium, ovarian, bowel are prime examples, but I expect to see this in breast, even prostate, pancreas, and other things. And therefore, it's important for cancer clinicians or health professionals working in cancer care to be able to counsel these women and deliver this from a test counseling and giving results. But we do not have enough genetics colleagues anywhere in the world to be able to implement this at scale that we need for patient and population benefit. So we need to look at models doing it, and therefore, to help bridge that gap and the need, we develop these models in a fairly comprehensive way. It's a multidisciplinary team which was involved. We got back funding for it from our Northeast London Cancer Alliance and the North Central Alliance, and we went on and developed this. It took us about a year or so, or maybe over a year. We also had a PhD fellow working on it, Dr. Kalra, and so it was a big team effort, shall we say? And then we put it on our platform, which we see available for all CPD and education resources, and we got to kindly agree to make it freely available for anybody internationally. I think after COVID, it's made freely available on the.
That's very, very generous. And Ranjit, just to clarify for some of our listeners who may not be aware, or members of the public that are listening, what we mean by mainstreaming is genetic testing and counselling that's delivered by non-geneticists, so cancer clinicians providing that counselling themselves and requesting that testing.
Absolutely. It's we mean the non-genetics health professionals delivering the counseling and testing, and that's really the way that we need to move. Yeah.
And Rachel, I just wonder if you could give some of your reflections in terms of the development process of the modules and how things works. And
I think just to add on to what Professor Manchanda has just said, I think endometrial cancer by its nature, is often very treatable and often just treated with surgery if it's diagnosed at an early stage. And in the UK, that surgery is often done within special units, and the patient may never need to see a medical oncologist or a clinical oncologist, depending on their disease. So I think he and his team rightly, and the wider project was kind of designed and has identified that actually a lot of these patients are seen, in locally to them, and they may never, I'm not explaining this very well, sorry. They may never see oncologists. And so actually there's a real importance to bring genetic testing to where the patient is having treatment. The patient may see a surgeon and they may see a clinical nurse specialist as part of their journey. And actually those people who are involved in their cancer treatment are really best placed to have a discussion with them about genetic testing. So actually by creating resources where we can educate, healthcare professionals and help enable them to provide that care for patients, I think is really important. And the work with the modules and wider work that Professor Manchanda has done around educating healthcare professionals and genetic testing, I think is really trying to fill in that gap.
Thank you very much. Hamda, any thoughts, final comments?
So I work also within the Women's Precision Prevention Clinic, but I also primarily work at Queen Mary, and I work on a study called Detect2. So this study offers patients genetic testing, and we're offering patients, so it's a randomized control study, looking at if direct-to-patient testing is equivalent to the main thing within the NHS. So patients are either randomized standard of care, which is a blood test, or they are randomized into, we call it the digital arm or the direct-to-patient testing arm, where they receive a saliva sample kit at home. And so this is definitely an amazing study, which will hopefully perhaps be implemented, we hope, in the future on our NHS practice. And we're finding that we're having a faster turnaround than our current healthcare practice. And this is definitely something that can be implemented into healthcare in the future. We know that, we need new scalable solutions to be implemented. And I think, saliva sample testing is just as accurate as blood tests. But this is definitely something we'll see more within the NHS. Yeah.
That sounds really fantastic, actually. I can't wait for the results of that trial. And Ranjit, just before we finish, interested if you have any take-home messages for our listeners about genetic testing for Lynch syndrome and about the modules.
I think it's absolutely imperative that we implement it. It's sacrilege not to be able to do the molecular testing and offer genetic testing to people who are eligible. It's important not from just a personalized treatment, but secondary cancer prevention and primary prevention relatives perspectives. It's standard of care, and it's not a difficult thing to do. And hopefully the modules will facilitate colleagues, both nationally and internationally, to take this up and offer it to their patients. It's important to increase awareness about this. And it's important, I think, for patients also to be aware and make sure, also for them to make sure that they get that test result or their clinician is able to offer it to them. I think it's a journey we're on, and they're clearly early adopters, and then there'll be people who'll gradually pick it up. It's going to take a few years to implement. It's not going to happen overnight, but it's really important. And I think IGCS and yourself, Paul, in this role have a huge role to play from a global point of view. And most cancers occur outside the UK, not inside the UK. So we are hugely grateful, I think, from the global perspective, to have this opportunity and to be able to work with IGCS so that this can be made available more broadly. That's really important for patients around the world. And so I'm extremely grateful to yourself and to IGCS actually for doing this and for increasing awareness of this issue, and also the opportunity for clinicians to be able to feel more comfortable and be trained in this to be able to offer it. So I think, we can't, as gynecologists, we can't ignore it, or gynae-oncologists, we can't ignore it.
Before we finish, I'd just like to thank you all very much for sharing your knowledge and experience with us and the IGCS global community. And I found this session really valuable. And I also thank you very much for sharing the modules, as I say, at no cost. They're available to the world, to any clinician that's caring for patients with endometrial cancer. So thank you for that. And to our listeners, thank you very much for tuning in. We encourage you to visit an IGCS Education 360 learning portal for all our educational offerings. And with that, I will draw this to a close.